Good morning, everybody. Thank you for those of you who are joining us today. This is a special event we're doing, sponsored by the Department of Medicine, with a number of faculty joining us today on the panelist side. As you know, we usually do medical grand rounds at this time. We did not have a medical grand rounds last week, given the winter break, but it was always our plan at some point during this break that we felt we should do some sort of town hall like we're doing today. As many of you know who have been with us throughout the year, we've used medical grand rounds at the very beginning to update on what's going in the hospital in our community. And we want to do essentially what we've been doing the first 15 or so minutes and expand that to really the whole time we have today, however long that is. So thank you so much to all the panelists who are with us today. And there's a number of panelists. I think I have up to 25 people on this side joining to help with this town hall today. You know, as a frontline provider, one of the things that's been important for me is anything that makes me feel less anxious, the knowledge of knowing what's going on. I want to make sure that everybody else has that same opportunity as well. And all the people here have been so crucial to helping that happen. I think I truly believe that in academics, the key to us decreasing anxiety is knowledge. And I think that's what everybody wants. So the goal here is simply to provide that. That's all we're trying to do in these sessions. So please let us know how we can do that best. And we're looking forward to you asking questions today. We're going to have some updates that probably go for about the first half or so of the time. Please feel free to ask any questions in the Q&A function. I think all of you know how to use Zoom pretty well by now, but please put questions in your Q&A function, and all of you can answer, comment on questions, and also can upvote questions. So please do that. And please start asking questions that you may have as soon as possible so people can upvote it and give that opportunity to see what's the most pressing questions. We'll try to get through as many as we can. I don't know exactly what to expect today because it's our first time doing anything like this, but we want to answer any questions you may have. With that being said, I'll stop talking and I'll start introducing our first presenter today, Dr. Will Collins. Thank you for providing us updates throughout the year. Will's going to update us on really what's going on in the hospital right now.
Thanks, Errol. So hopefully everybody can see my slides. I'll just jump into it quickly. I'm going to start with numbers nationally, and then we'll focus down to get to the hospital numbers as well. So nationally, these are our curves for, excuse me, of course I have to clear my throat. So we have red here, the curve for new cases, blue is the curve for hospitalizations, and gray is the curve for deaths. You can see actually these curves are starting to level out a little bit, perhaps approaching an asymptote. Hopefully some good news there, although we're not totally sure what will happen with travel over the winter holidays. And certainly when you look at California, we're still very much one of the epicenters of the surge. You can see pretty dramatic rises in cases and deaths here in the last several weeks. And something that has been, of course, important for this audience is the dramatic rise in hospitalizations in the state, and when with it a significant fall in availability of beds, particularly ICU beds. As of yesterday, per the state's public health website, we had just under 14 beds available, or excuse me, 1,400 beds, ICU beds, I should say, available in the state. In the Bay Area, again, we're still seeing a pretty significant surge. This is showing number hospitalized per 100,000. You can see, again, Santa Clara is the highest compared to all the other counties. It's the purple dotted line there. And looking actually at bed availability in Santa Clara County. So this is showing ICU beds, the different, the different colors here. So the orange is patients with COVID-19 in ICUs, the blue is non-COVID-19 patients, and the gray is sort of a projected additional capacity that includes surge capacity for hospitals. That red line is what's called the standard maximum capacity, which is basically if all hospitals were operating as normal, this would be the expected capacity for the county. So you can see we're pretty close to that for ICU beds. And if you look at non-ICU beds, we're basically at that, although there is here built in what they say is a roughly 14% additional bed capacity if you can include surge capability for hospitals. Comparing ourselves to other hospitals here in the county, this is over the last 2 weeks, we're the second or third in terms of total number of COVID patients we're taking care of for our census, and actually have had the most ICU level COVID patients. And certainly our census continues to rise. This is showing both our census for floor and ICU level up to December 21st. And as a snapshot, and this may already be out of date, I think the positive now is over 100 this morning, but as of last night, we had 96 positive in the hospital with 29 in the ICU, 51 at med surg or ops level, and 16 in the ED when I took those numbers. The 7-day averages for the last week, we had an average of just over 80 with 23.6 in the ICU, 12.9 of which needed ventilatory support at some point, which was up from 57 the week prior. And just one last thing is where are our patients coming from? So looking at least starting November 1st through yesterday, the majority are actually coming through the emergency department. We counted 157, 13 of which came from SNF, and then there were several direct admits as well. We also have taken transfers, a total of 24 since November 1st up until yesterday. 13 of which were transfers for a certain region, and then 11, actually 21 total were what was called mutual aid, 11 of which were COVID positive. Mutual aid, just so people are aware, basically there was an agreement starting December 4th that if another sister hospital is at an emergent or near emergent threshold in terms of their nursing ratio, their physician ratio, or their just physical space to house patients, then we would try to help out. So since that time, as I said, 21 total mutual aid transfers have occurred, 11 of which were COVID positive. And just looking at transfers over time, this is for COVID-19 positive transfers, you can see that we didn't have that many until that mutual aid process started, and then we took quite a number in the week after. And since that time, actually, the numbers have started to come down. So I wanted to thank particularly Jake, Rudy, and Salma who helped with the numbers this week. Some of the other data team members who normally help are deservedly on winter break. So these folks really helped out getting these numbers. And I'm going to stop sharing. Let some other folks give more updates.
Dr. Collins, thanks so much for those updates, and again for providing these updates throughout the year. Dr. Huja will move on to next to talk about, so Dr. Collins talked about what's going on, and Dr. Huja is going to talk about our response to it.
Sounds good. Thank you, and good morning, everyone. I'll show you some of the COVID surge planning that we have been doing on the wards, and then the ICU will be presented by Dr. Weinecker. So as you know, and as Will has nicely described, you know, SHC and Valley Care are in constant communication with the state and the local counties about capacity. In fact, just yesterday, we took 13 patients from outside hospitals, and that was a mix of COVID and non-COVID. But the ICU beds really remain the bottleneck of hospital capacity. Our county is around 11% ICU capacity right now, so below that 15%. So it's critical. And about a third of our COVID volume is in the ICU, and that's different from the spring when it was closer to about maybe 20% or so. So now we're close to about 30%. I thought it would be helpful for you to see our average team daily census across this year. And this is for general medicine. And I really want to thank Jeff Chi for all of the data that he's provided for some of these graphs. You can see in January, we had, you know, some peaks that were due to the post 500p opening, but pre-COVID. COVID hit, and then we saw that down turn in volume dramatically across the institution with the rebound effect over the summer. And if you see here, you know, 16 is sort of our average peak. The medicine teams can actually each take up to 20 patients, but we try to avoid that. 20 is the ACGME cap, but it's really quite busy when that happens. So we have what we call a working cap of around 16, and that'll come into play in a few minutes. And then you can see the trends here. So although they've gone down, they're still not low, and we do have a mix of COVID and non-COVID patients. Now, factors that have helped our surge planning include the fact that our departments, faculty, fellows, the divisions have really contributed and stepped up to helping and volunteering for surge staffing. It was so nice to see residents doing this, and fellows under the leadership of Julia Chang, who's also on this panel, has really helped give some extra support. The GI service, for example, increased their cap to decrease overflow to the medicine teams, which has been incredibly helpful. As surgical volumes have gone down across the institution, that has decreased the inter-service transfers. So patients that were on surgical service that may have had acute medical problems and then requiring them to come to medicine, that number has decreased. Mutual aid, which Dr. Collins just described, is a very thoughtful process, and like we said, we did take several patients yesterday. We've had APPs deployed from other services, departments across the institution to help as manpower on the teams. And fortunately, the oncology volumes have been stable. As we know, general medicine at one point across the past few years has been up to 30 or 40% of general medicine volume. So right now that is stable. And then a shout out to our case managers who have really been proactive with throughput and discharges, transfers to skilled nursing facilities. Now, all the symptomatic COVID ICU patients and, will eventually come back to the wards. Sorry, all the COVID ICU patients will come back to the wards. Some of them start on the wards, go to the ICU and then return. And so we have to prepare for that. We did create an early ICU de-escalation policy, which is being fine-tuned to sort of help decompress the ICU as best we can. And then subspecialty volumes are not always predictable. Hematology was quite busy yesterday, so we just need to keep these factors in mind. Provider illness is really something that we have to be aware of, not just from exposure, but as everyone is eager to get their vaccines now, we know from the clinical trial data that the second dose of the vaccination is the one that really causes the symptoms. And if providers are febrile, they're not allowed to work. And so in our surge planning, we are taking that into consideration for the mid-January timeframe. And then EMTALA transfers we're required to take, and those do come to our service. So some people like to see the final platter, others like to peek behind the kitchen and see how things are made. So I'm going to hope to accommodate both. Here you can see the 6 medicine ward teams, hard cap of 20, but let's look at our working cap of 16, which gives us about a census of 96 that we could accommodate, but a buffer that we wanted to fold into this. Now we have 3 levels of surge planning. You can see your level 1, level 2, and we have a 3rd team in place as well with names locked in should we need them. Right now we are only half filled with level 1 surge, and level 1 surge has been active for 2 weeks. Dr. Poonam Hosmani is staffing that surge team. And Dr. Caitlin Contag is the resident who volunteered to help out. So thank you to both of them. And you can see on the surge team, we have a hard cap of 10, but we're going with a softer cap of 8. So each surge team could accommodate up to 24 patients should we need it. And so just for a little more granularity, you can see if we have all of our teams active, surge and existing ward teams, we would have a working cap of 168 patients we could accommodate. To give you a sense of where we are this morning, we're at 93 patients total. If we go up to our hard ACGME cap, we could accommodate 210 patients. And we also know that, the ACGME would be flexible on caps during times of extreme crisis, but we really want to work towards not overwhelming the team, but it's good to know that we have that buffer. And then finally, there are so many people to acknowledge and thank. I want to just list some of the names here, and I'll stop sharing and turn it back over to you. Thank you, Errol. Errol, you're on mute.
Sorry, I didn't click off. Thank you. Thanks for Dr. Ahuja. Dr. Weinecker is going to now update from the ICU perspective. Just a quick thanks for all the great questions coming in. We do have panelists who are here mostly to answer questions as come up, both live and in type. And some questions, if we have time, I'll bring into the ones that are answered in type to answer live as well. So we'll try to answer as many questions as possible, both live and in writing. Dr. Weinecker, thanks for providing updates at the ICU level.
Sure, thanks. And somebody had to be on mute at some point, so maybe you've gotten it out of the way for the yeah. So the ICUs are getting busier. It's ramping up pretty quickly. We have 36 patients in the ICU, 5 of whom are currently boarding in the emergency department. We have 9 new patients admitted to the ICU overnight, and there were 20 ICU consults overnight, 20. We have activated 3 surge teams and are pulling or having house staff come to us from various departments and have a plan for how to sequence that. Larry Katz-Nelson has been instrumental in making that work for us, and Dr. Sagal has also been very helpful in making that happen. We have plans to accommodate up to about 75 ICU patients with our current sort of standard of care in terms of how many patients are on a, how many providers are on a team. If we get beyond that, we may find ourselves looking at a different staffing model. There was a question about, do we plan to increase ICU beds? The short answer is yes. We've been planning for that even since March. If we found ourselves in a situation like we're in now, there are 106 staffed ICU beds. As you heard, I mean, as I said, there are 36 ICU patients on the COVID team, but just to look at the medicine teams, ICU teams in general, we have almost 60 patients. So there are still other patients who are requiring ICU care besides the COVID patients. I've been working very closely with Dale Beatty, the Chief Nursing Officer, and Rudy Arthofer and others to determine exactly how we're going to open and where we're going to open more ICU beds. We have already opened the L4 unit, which was originally intended or designed to be an ICU, but when we opened 500P, didn't really need those 20 beds to be used as an ICU. They are now being used as an ICU for COVID patients. So currently we have K4 and L4 that are ICUs for COVID. The next unit will probably be M4. And then we have other units that, particularly in the 300P, that can't be used for COVID, but we've got plans to increase that. There was also a question about what determines the need for ICU. There are a lot of things that determine the need for ICU for any patient, and COVID patients aren't excluded from this list, but we do admit patients with COVID who need high oxygen, who have high oxygen requirements, and so that's one of the things that that keeps us that has kept the ICU so full. About half of the patients that we have right now are actually intubated and on mechanical ventilators. So it is a fairly sick group of people. And one more thing just for awareness is with all of these patients, we are becoming challenged with drug availabilities. A number of the things that we do normally use in the intensive care unit for these patients are beginning to be in low supply. Some things we can get from Packard, but not everything. So we're like inhaled nitric oxide, for example, which is a pulmonary vasodilator. So we're quite busy. The ICU faculty are, many of them are working in the ICU every other week, which is pretty intense, as you can imagine. But we do have plans to increase staffing as we need it. Nursing is also working to increase staffing of both nurses and respiratory therapists, which are, as you can imagine, getting tight as we think about adding more than our 106 staffed ICU beds. And sorry if I went over, but it's been pretty active.
No, Dr. Renniker, thank you. That was absolutely perfect. And a number of questions that we'll get to in a little bit, but definitely many questions that you can help us answer. So thank you for the update. Thank you for being here. Next, we'll move over to Dr. Megan Mahoney. I have your slides here, so I will start sharing him.
Hey, thank you, Errol. It's great to be with you all today. I'll be reviewing the outpatient COVID response, but really this is a list of accomplishments that have manifested over the last 9 months on the part of Stanford Medicine. So as we all know, there are continued efforts in the community for patient testing. The services are open 7 days a week with extended hours, even open through Christmas Day at the Galvez testing site. You can take a look at the website to understand the specific hours of operation, but to date, on average, there are 1,600 to 1,800 tests being done a day across the 7 sites, with over 200,000 tests performed to date. I mentioned that last time that there is this unscheduled or drop-in same-day testing service at the Galvez parking lot, will be open on Christmas Day. Thank you for all of the incredible staff who have volunteered to work that day. And then also the testing positivity rate has been steadily increasing. And right now it's at 4.57% as of last week. Our risk reduction measures continue. So luckily PPE on hand continues to be stable. The virtual visits are around 37% of all of our visits, which is a slight increase compared to the past week. And so it's been really incredible to see what the ambulatory transformation team has been leading in all of the subgroups, so we can really transform what we're doing in the ambulatory care space. I think everyone received the visitation policy update, more restrictive visitation policy currently given the circumstances, and that includes the ambulatory space as well. And then, of course, we have, after pausing for a moment among the medical staff, they really wanted to wait for others to go before them. But this week, over the last couple of days, I've received a number of selfies that I had to include here of medical staff who have been so grateful to the team, the heart team, everybody who's staffing that clinic. It's a really joyful moment. And I'm so glad that Brian Bowman and Neeraj are here to talk about that. It's been incredible to work, to see the work that's coming out of that team with Tim Morrison and everybody else. And so just a fantastic time that we've arrived at. On the next slide, I wanted to I know that Upi Singh and Stan Darenzinski and Marissa Hayubar are also on the panel, but we thought that we would just let people know that the FDA obviously has issued an emergency use authorization for monoclonal antibodies. Specifically here, we have the bamlanivimab medication that's available for infusion for mild to moderate illness for those who have certain risk factors. And we have the list of risk factors available on the intranet, and we might be able to even present it today. For the intravenous dose that's to be administered as soon as possible after a positive test within 10 days of symptom onset, the request needs to be issued to the email address provided here, and then a response will be received within 24 hours. And so that's a fantastic resource. If there are any operational challenges in getting the infusion here, the pharmacist who is also collaborating on this mentioned that CVS is also offering infusions at skilled nursing facilities. So that's also a resource. So in addition to, of course, the comprehensive and coordinated outpatient care that we're providing, this is a resource for those who have mild and moderate symptoms. So thank you, Errol, for showing the eligibility criteria. And then I also heard from Meyer Artandi that the Crown Clinic is still going strong, seeing the more high-risk patients or patients who are released from the hospital. And they currently are following 70 patients, and they still have capacity. So with that, I just wanted to acknowledge that this is the end of the year, and that I love that we all got through this together. And I just am so appreciative to this community. Thank you.
Dr. Mahoney, thank you so much for that great update. I also want to add in for the email reminders that went out this morning at 7:45, all the information about the monoclonal antibody infusion is in there, including the email you need to contact as well, and the criteria, as well as a number of other resources. So please check that if you guys need it sent out, or if we need to, I can send out a follow-up email after this as well with any additional resources. Dr. Mahoney, thank you again. We'll move on next to Dr. Neeraj Sehgal, our Chief Medical Officer, who's just going to make some general comments about everything. Dr. Sehgal, thank you so much for being with us today and everything you've been doing for us since you joined us at Stanford.
Good morning, Errol. It's a pleasure to be here. Yes, as I've told many, my onboarding officially has ended. So I recognize, I guess I'll make a couple of general comments since I know a number of folks on the call, including Brian to follow, will give a lot more details that people are looking for in vaccine. I just wanted to make a couple of broad comments, just taking a step back, just to acknowledge the situation we are all currently in, both here on our campus, both our colleagues at Valley Care, as well as just the community, as you've seen now with a number of the great visuals that Will shared at the data. A lot of the focus on Santa Clara County, I think the one piece I would also add in, not to add more concern, is just San Mateo County. So for those of you that are familiar with San Mateo County, you know they have perhaps less hospital and ICU capacity than other counties, which means that we may also be part of trying to be the solution to help elements in San Mateo County. There is increased, I would say, collaboration and connections across the counties, as well, looking where capacity exists. So there's probably more mutual aid transferring happening across counties more than there was perhaps a week or two ago. I think we are likely to see that continue. I think Rich asked in the chat that Nira responded to, of, what happens when we're starting to get to a place where we're hitting our capacity. And I think those are the same conversations that are happening now from county to county. And I think it does reflect, unfortunately, the projections we were hearing about a few weeks ago of their sadly kind of meeting exactly where we anticipated. The other piece, just organizationally, I will say, recognizing the last 10 days to 2 weeks between the surge that has grown massively, because the community transmission rates are, of course, going up leading to the surge. It also means our own testing demands have gone through the roof. We're breaking records literally every day on test demands, and it's just stretching our own capacity. So while the test turnaround times in the ED and the preoperative area are still actually quite good, as hopefully is the experience you're all having, when you're starting to get into some of our ambulatory test sites and off sites for asymptomatic, as has been evidenced in the chat, the turnaround times are just getting longer, and that's for a whole variety of reasons. Some of it is reagents, which we fix, some of it's equipment, and some of it's honestly just it's getting slower. And that test turnaround time, by the way, in some of our partnering community hospitals, they're starting to have that issue with their actual acute inpatients. And so you can imagine that if you are taking care of a surge and your COVID test in the hospital setting is going out to 24 plus hours, we're talking about being back where we were in March and April, and that's a real problem. I'm having spoken to a number of my colleagues in some of our community hospitals. It is, while I'm humbled and sobered by what's happening here, I'm even more humbled and sobered by talking to hearing what you can sense in the angst in a lot of them. And then, of course, the other large initiative has been the vaccines, which I think we can all agree has not gone perfectly or by plan. I think we've tried to work really hard the last several days to make a few course corrections that were important. I hope own some of the mistakes of the communication and pieces that we certainly could have done better. We actually maxed up, almost did 2,000 vaccines yesterday. So last week, the goal had been trying to ramp up to 1,000 vaccines a day. We did about 800 on Saturday, as you see on the dashboard. We hit about 1,200 on Sunday, 1,600 Monday, and we hit almost 2,000 yesterday. So we're rapidly getting through that first wave of almost 8,500 people very, very quickly. In fact, we'll probably be through most of that first wave over the next couple days. The main piece, as Brian will talk more about, is just where we go next, recognizing we don't actually have the Moderna vaccine in hand. And so I'll let Brian talk through some of the operational pieces, but just to point out from a staffing perspective, which I guess will be the fourth bullet. So we've talked about surge, we've talked about testing demand, we've talked about vaccine, all of which require people in most cases. The vaccine team right now is almost 65 people that are making that happen because we're doing the vaccines between 7 a.m. and 11 p.m. Those are the hours we wanted to try to accommodate to try to get as many people in there as possible. You can do the math that in 16 or 17 days, we need to start preparing for not just first doses, but second doses as well. And so there's a lot of planning beginning around those elements. And the fourth piece is just staffing. So as the community transmission rates go up, of course, that means some of our healthcare workers are also being infected or being exposed or being quarantined. And so there's a lot of work happening in the operational areas for nursing, therapists, others, trying to tap into as many of our own workforce as we can. And we've been so far pretty fortunate, and more fortunate than some of our community hospital counterparts, in having access to some additional staff. So I just share again, I'm trying not to be overly grave, but I would say that the circumstances of today certainly continue to feel quite different than they were a couple of weeks ago. We were still kind of talking in hypotheticals, and as all of you are hearing from the numbers, we're now in it. We're no longer surge planning. We are now surge managing. And so I say it because this may be a few weeks. We know, as people saw the news report yesterday, apparently yesterday was one of the largest travel days that people have seen. They showed pictures of packed airports, and it just, you hope all of this is feeling real to people, and trying to do our best to help curtail it. So We have tons of people working. I appreciate people's patience. I know the communication is really hard. This is like many things in COVID, it tends to highlight the areas that we tend to struggle with as organizations already. And in a large, complex organization, communication is difficult. So we have been trying to put out daily communications with certain information. We are meeting with the clinical chairs every day. The operational leaders meet every day, and we keep trying to keep the information flowing from people who are closer as well. It is imperfect, and so we welcome suggestions on it. We're really trying to get as much information as we can, realizing oftentimes the information is changing really quickly. And so as we try to get the quote perfect communication out with all the specifics people are looking for, those specifics also kind of evolve over the course of the day. And so just sharing candidly, that's been part of the tension of not hiding information, but just trying to get it out as quickly as we can in ways that provide the specifics folks are looking for. So I really appreciate everyone's time, energy. Everyone's really tired. It's been a long 9 months, lots of sacrifices. And with the holidays in front, I hope folks get to maybe spend some time with your friends and family in a safe way. Also maybe spend some of your time planning next year's holidays. Let's hope they look quite different, and just continue really being very grateful for our community here and everyone leaning in, trying to do what we can to support our patients and support each other. So thanks, Errol, for having me. And I know Brian will probably touch on more information around the testing and vaccines.
Dr. Stigall, thank you for everything you've been doing alongside all the leadership, and thank you for being here today and helping with updating and answering questions. One of the things we're planning to do as well, given the vaccine rollout, is we wanted to hear from multiple perspectives, including our house staff, as well as residency leadership. We have Adrian Castillo, who's the chief resident for the residency program. Adrian, could I have you comment first and just let me know how the residents are doing and how things have been going from your perspective?
Yeah, absolutely. Good morning, everybody. Thank you for having me here. I'm Adrian, for those I haven't met, one of the chief residents this year. I think it goes without saying that the initial vaccine rollout left many of us angry and disappointed. And I'm proud of our residents for deciding to go and stand up for a more equitable distribution of vaccine for all frontline healthcare providers. And we're grateful that I think Stanford heard our concerns and while it was a little bit bumpy, made some changes so that now all our frontline residents have been vaccinated, including all those who are volunteering their time to staff our surge teams, giving up their holidays. And so we're very grateful that that was, I think, accounted for. I also want to highlight how moved I think all our residents were by the outpouring of support we felt both from individuals in the department and the department leadership. That really was just, I think, incredibly touching. And we had many residents express to us, both individually and on social media, that they've never been prouder or more grateful to be a part of this department. So thank you all on behalf of our residents. I know looking ahead, we're very looking forward to working with GME to make sure to find opportunities for residents to be more involved in kind of leadership across the institution, to make sure we have adequate resident representation to hopefully avoid events like this in the future. So I think, on the whole, we are grateful that I think things have changed and our residents are able to get vaccinated, and we're hopeful to try and find ways to, again, just make sure our resident voices are heard across the institution. Thank you.
Dr. Castillo, thank you very much. And before we hear from Brian, perhaps Dr. Chang as well, a past resident of our program as well, an endocrinology fellow, Dr. Chang.
Hi, yes, thank you so much for including me in this panel as well. I just want to echo what Dr. Castillo said. We fellows definitely stand in solidarity with all of our frontline residents, and we have many frontline fellows as well. So I'm really grateful that due to the efforts of this group in the last 5 days, especially, a lot of our frontline fellows, if not all, have pretty much been vaccinated or been invited to be vaccinated during this first wave, and that there are plans in place for our other patient-facing fellows to be vaccinated in the upcoming wave. I think what's been great about having us all come together is that we're able to connect more, and I know I'm personally working with a lot of individuals now in the leadership on how we can get our non-critical care fellows, but those who are board certified in internal medicine to help out in the ICU or wards as needed if our patient numbers continue to surge. And then lastly, I think inclusion from the resident and fellow level has been a key theme in the last few days. Transparency, honesty, open communication. Over communication, I think, is better than under communication in a time like this. So look forward to working more with the leadership and hearing more messages from everybody.
Thank you, Dr. Chang. Well said on the communication part. Both Dr. Watellis and Dr. Weinecker were commenting, and perhaps you comment about the volunteer work that you guys have been doing as fellows and house staff. Dr. Watellis, did you want to make a comment on that? And actually, in fact,
Yeah.
Dr. Watellis, would you like to any comments you'd like to share would be greatly appreciated.
Sure, I'll be brief, and thanks for the opportunity to be on this panel. And I just want to acknowledge, I know a number have said it, but I really want to acknowledge that residents and fellows across the institution, and most definitely in the Department of Medicine, have really been simply phenomenal throughout all this. The Department of Medicine residents are currently fully staffing the ward's COVID surge team, as well as half of the spots on all of the ICU surge teams. And our goal, which we've mainly been able to achieve, has been able to do this on a voluntary basis. And the spirit of volunteerism, including people volunteering to delay their holidays, and the dedication to caring for the community has really been simply phenomenal and inspiring. And I just want to make sure we all acknowledge just the incredible work, clearly, of so many people. But in this context, I really want to highlight how amazing our residents and fellows in the department have been.
Thanks so much, Dr. Watellis. And then in charge of GME, Dr. Katz-Nelson, thank you so much for joining us as well today. I'd like to also ask you to make any comments if you'd like to.
Sure, please. Good morning, everybody. I gave Cushing's Grand Rounds at Medicine Grand Rounds last February, and that seems like 5 centuries ago at this point to me. So a couple points real quickly. In terms of surge management, I am working with Ann Weinecker and Angela Rogers and Neera Ahuja to see what I can do to help ensure that there are volunteers from across the institution to support the medicine residents and anesthesia residents and ED residents who are covering the critical care units. And hopefully we don't need more, but we need to prepare for the worst. So that I'm happy to do. If with regard to the vaccines, I think Adrian put it right. There was a very bumpy rollout. That's a good way of putting it. Understatement, I think. We have worked very hard over the last 3 to 4 days to ensure that all residents and fellows in the patient-facing areas, particularly the critical care units and the inpatient wards, the emergency department, have the first wave of vaccines. There'll be more invites coming out over the next couple of days to ensure that we've finished that wave. And then all of the other residents and fellows will be receiving invites over the next week in the second wave for invites for the vaccine. So we're working very hard to be efficient in getting the vaccines out. And as both Adrian and Julia well said, we're working, this is a great opportunity for us to work with residents and fellows to have them more engaged in hospital processes. And so that opportunity exists, and we're working hard for that too by the day. So I look forward to having more representation. So things like this shouldn't happen again, and they'll give the residents and fellows more of a voice in what's happening in our institutions.
Thanks so much, Dr. Katz-Nelson. And again, thank you for being here and for your advocacy. Dr. Bowman, let's go back to you and see if we can hear you now.
Okay, we'll try it again. So symptomatic testing, I was trying to say, is our most important focus right now, because obviously when you're symptomatic, you're out of the lineup. And we want to get people back in the lineup as soon as possible, because although our positivity rate is higher, it's about 10 to 12%, still 90% of us who have symptoms are not testing positive for COVID. So the way we're doing that is we have a drop-in clinic for all physicians, residents, fellows, and faculty at the Hoover Pavilion that is every day from 8:30 to 10 in the morning and from 1 to 3:30 in the afternoon. So if you have symptoms, please drop in there for testing. The turnaround time on that is still better than the asymptomatic testing, because we're expediting testing on all symptomatic physicians and employees. But it's going to be a day, something like that, probably right now. So we've opened up another potential avenue, which is an urgent testing process where you actually have one of the Cepheid or other urgent testing platforms or rapid testing platforms that will give us a result within a couple hours. And we've had the ED doing those. We did a soft start and it worked well. We publicized it yesterday and we have already overwhelmed our system. We are going to be working on that today. One of the important things is we need to regulate or, sort of throttle the input on this. I think it was Adrian, I think I talked to you about this in terms of making sure that house officers, when they feel like they need testing, check with your program, check with in other departments, program directors. In this department, the chief residents are willing to take this on and just make sure that anybody who really isn't in dire need of getting back on service within 24 hours does not use this modality, please, because otherwise we're just going to have the whole system be overwhelmed. But I do think that it'll give us an option that's really critically important. The other thing I want to say is that our testing facilities are open on Saturdays. They've never been open on Sundays, and we're scrambling to try to improve our hours and to be open on Christmas, New Year's, and Sundays, given the volume of symptomatic employees that we have. And I'll get back to everybody with announcements about where we're at with that as those dates approach. I know, Errol, you wanted me to talk about our OC Health infection rates as well. And I just wanted to share with you, you guys have seen this before, and you can see, excuse me, you can see here that we had a huge jump just starting in October, really after Halloween, real big leap after Thanksgiving. We are somewhat plateaued. It's still rising somewhat. Our last 7 days, 120 instead of around 100. But the good news is that at least our positivity rate has not been rising over the last several weeks. So hopefully that's going to stay at a plateau. The symptomatic positivity, as I said, is 10 to 12%. And our asymptomatic positivity, I won't show it, but is also plateaued at around 2%. So those figures are high, but they're not doubling themselves every week, which is what I was really afraid of. So far, we're holding steady on that.
Great. Thank you, Dr. Bowman, and for those updates. I appreciate it. We have a few questions here that I'll come back to naturally about vaccine rollouts, but I'd like to keep going with the agenda updates here. Next and last we have is Dr. Ben Pinsky. Maybe appropriate to finish with you last. Dr. Pinsky, you have been with us since the first COVID grand rounds before we were even fully in Zoom. Thank you so much for really everything you've done throughout the year as well. I'll turn it over to you. And I'll stop Brian's screen share here so you can share slides if you have any.
Great, thank you. Thank you, Errol, and thank you, everyone. I'll just show a little bit, a couple of slides on, there we go, about turnaround time, which has been brought up by a number of the speakers already, Niraj, Brian, and others. This just echoes what has already been said. So our outpatient ambulatory asymptomatic testing turnaround times are slower than we would like to see. You can see that here with the 7-day average of collect to result based on collection location. And you can see for the Galvez lot, it's over 72 hours, about 3.5 days here. However, as has already been mentioned, we're doing quite well as far as the rapid testing and also urgent testing for our symptomatic patients. You can see, this is hard to see here, but stat ED turnaround time is about an hour. The urgent workflows, urgent ED is about 8 hours, and that has to get over to the Hillview labs, so that's pretty good. And for inpatients and other specimens collected at SHC, we're less than 1 day. As Brian mentioned, occupational health, we're a little over a day for testing, but these urgent workflows have been implemented, and we'll be getting those tests back more rapidly. On the right side of this, you can just see the positivity rates for the various different locations. So from the ED, it's 17 or 18%. In the ambulatory, we're close to 10%. Overall, right around 8% positivity rate over the last week. And then I should just mention, going back to turnaround time, our overall turnaround time, despite these delays with ambulatory testing and testing at the various Galvez lot and so forth, is still right around 2 days, 48 hours. So not that bad considering the overall test volumes, as well as the various different behind the scenes things that we've been dealing with, like allocation of reagents and breaking of instruments that have been running 24/7 for the last 8+ months. So there is some more good news on the horizon. We have got some new instruments for high capacity testing. This just went online this week. These are liquid handlers in biosafety cabinets. These are extraction instruments. There's another robot to set up the PCRs, and here are the PCR instruments that can run 384 well plates. So we anticipate that our turnaround times will improve as we ramp up this testing system. We are currently in the process of training more staff to run this. So hopefully you will see turnaround times decrease over the next several weeks as we roll this out. So that is all I have. Thank you again for allowing me to present at these meetings.
Thank you so much again, Dr. Pinsky. As we wind down, so we have about 5 to 6 more minutes left. We had lots of questions, and I'm really glad that we got to answer so many questions with the panelists. I just want to thank additional people who didn't necessarily give updates, but have been in the background answering questions, supportive. Dr. Verghese, Kathy Garzio, Sherilyn Stoltz, Tate Shanafelt, helping answer any wellness questions. Dr. Singh as well, joining us today. And of course, Dr. Harrington, who helped us out today, for joining. And thank you all of you. Many of you have been with us all year providing updates. We will just get through a few questions here. One of them I think was just answered, but I'll still go back to it. A question I would expect from no other than Dr. Bhatt Ami asked, how can other faculty and people in our department help support during this surge, during this time? Any thoughts or comments? I think Dr. Weineck or Dr. Huja on that. Thanks for asking that question, Ami.
Go ahead.
I was going to say thank you, Dr. Bhatt. She is actually signed up to be on our level 2 surge team. So we have solicited her help, and I don't know how the ICU part could be answered. I'll turn that over to Dr. Weinecker.
Yeah, thanks, Neera. As I answered in the chat just a second ago, at this moment, I don't know how you might be able to help the ICU specifically, except to help the hospital medicine guys, because many of our patients are coming from the wards. And so trying to keep things under control there is very helpful. If we get really busy, we may find ourselves, it feels really busy now, but if we get even busier, we may find ourselves in a situation where we have to have kind of a tiered model of care where an intensivist oversees people who are not intensivists taking care of patients. Nursing may find themselves in the same situation if we really get that busy. So far, and that would essentially be crisis standards of care, certainly not our usual standard of care. But hopefully we won't get to that point. We're all crossing our fingers we won't get to that point, but I really appreciate you asking that question.
Thank you so much. And I'm just going to focus more on some of these unanswered questions. Prince Shah asks, is thalassemia trait a risk factor similar to sickle cell trait? I assume that's referring to the monoclonal antibody infusion. So maybe I'll just generalize that question. If you have patients who have medical concerns that necessarily aren't on that inclusion criteria, can they still try to get their patients infusions? Dr. Singh, any thoughts on that perhaps? Or
Yeah, hi, good morning, everyone. So we're under the emergency use authorization criteria, and we do need to follow it carefully and document the reason for the infusion, since we will get audited for the samples. So the criteria are listed. If people have questions, you can use that email or contact us, and we'll be able to help. But thalassemia is not one of those.
Thanks so much, Dr. Singh. Next question here in the last few minutes, Kenzo Ichimura asks, is the sensitivity of the self-tested nasal swab test known? Is it high enough to rule out COVID with mild symptoms? And also just with the nasal swab being used for the color swab kits, Ben, do you happen to know any data on the sensitivity specificity of color, and is it high enough to rule out with mild symptoms?
I don't have specific data on the color assay, so that I'll have to defer that question. The specimen types, so lower nasal swabs are slightly less sensitive than mid-turbinate swabs, which are less sensitive than nasopharyngeal swabs, which are the most sensitive collection type. However, there's reasonably good data that the nasal swabs are about 90 or so, 95% sensitive compared to NP swabs. And there's a number of papers on that, including from Stanford, Bonnie Maldonado's group. And I can send that out to the question.
We'll go ahead and close this down. I'm going to turn it over to Dr. Harrington. Before I say that, I just want to thank again all our panelists, all the attendees for joining and asking such wonderful questions. Please keep us updated on how we can update you from our communications. Do we need to do this again at some point? Should we be sending out more emails from the Department of Medicine? SHT does a great job of communications, but we try to do it as well to keep you updated. So please let us know how we can do. Thank you again for everybody. And with that being said, Dr. Harrington, I'll turn it over to you.
Yeah, I just want to add my thanks to all the panelists who are working incredibly hard to try to both take care of our patients as well as vaccinate our entire workforce. So thanks to everybody for their leadership on this. As Errol said, we continue to cascade out messages to the divisions, to the faculty. And if people aren't getting enough information, please do reach out to Errol so that we can think of other ways to try to make sure that you're included in the communications. I hope that people are able to at least catch a little bit of a breath in the next 24 to 48 hours, but rest assured that that things will continue here, and we look forward to continuing to exchange information like this with you. So Errol, thanks to you for your leadership, thanks to all the panelists, and thanks to our many people in the department who dialed in this morning.
Thank you guys. Be safe, and we'll see you soon.